Hi, everybody. Welcome to this edition of the Cameroon Town Hall for Healthcare Professionals. If you're joining us, this is a platform we meet every fortnight to discuss on health issues that affect our country, Cameroon, and to bring our perspective on how to contribute in ameliorating the healthcare system in Cameroon. Today is going to be a very interesting session. We shall be talking about blood transfusion in Cameroon, challenges and perspective. But before we get to the topic, let me take a round to introduce a co-moderator, Dr. Brian Tegomo, who will be co-moderating with me, and as well as our chair for the Cameroon Town Hall, Dr. Monoken. Hello, Brian.
Yeah, hi, always. Always great to see you, and it's great to connect every other week on this platform, and really thanks a lot for really holding the vision of the town hall for this getting to 4 years almost now. I think this has been a very important initiative that has brought or shed light on very critical health issues in Cameroon. And both in public health and in medicine and in clinical research. And I think today we have one of those very important topics, which transfusion medicine, which I think we don't really have we haven't really had a previous speaker come talk to us about transfusion, blood transfusion. And I think it's a really fundamental and core critical component of any healthcare system. It's what's essential to saving lives in emergencies. Think about all the crises we've had in Cameroon and all the crises that we have in different parts of the world. So I think it's exceptionally critical, and it's not a topic that's I think it's being discussed a lot. And certainly in our context in Cameroon, we have lots of misinformations around blood transfusion. We have cultural limitations around the discussions around that and things. So I'm really thrilled that we have someone on the ground that's involved in this field of research, and who is at least involved in this area of medicine. So really looking forward to Simon's presentation today. Over to you, Elvis.
That's very true. A very important presentation, especially considering the fact that data shows that Cameroon needs about 400,000 pints of blood each year. And in 2021, only about 48,000, or I think 2020, only about 48,000 units of blood were donated, down from around 103,000 in 2019. That shows that there is a kind of a decline in the volume of blood that is being donated. And if you look at the national need for blood, about 400,000 pints of blood, then you can understand that there is a big problem of blood transfusion and blood donation in Cameroon. And so this is a very important topic, as you said, Brian. Let's hear from our chair of the Cameroon Town Hall, Dr. Mono. Hello.
Hello, Elvis and Brian. I'm always happy having you guys here. I don't know how you do it, but the consistency and everything that occurs in the town hall and the different important topics that we talk about. Transfusion medicine is something which is special to me. And right from my roots back in Cameroon, I did a little bit of clinical pathology before moving to the US, where a lot of people know I'm an oncologist, but in the US, you're also a hematologist and an oncologist. So I do a lot with transfusion. And it's always been important for us to know what's happening home, how safe transfusion is. And Simon is one of those people I've spoken to who is not only that he's driving that goal in the Northwest region, but he is someone who has a vision in order to change things and to make things better. And for us to be able to have access to one of the core components that can help save life. There are a lot of things that we cannot do without blood. So I think today we'll have a wonderful and excellent discussion to see how we can take things forward and how we can all contribute and help build a good blood bank medicine or good transfusion medicine in Cameroon and be able to help save lives. So Elvis, I think I'm looking forward to this discussion. We're looking forward to discussing what our strengths are, what our weaknesses are, and how we can improve those strengths and weaknesses going forward in Cameroon. So it's a privilege really attending this session.
Yeah. Thank you very much, Chair, and thank you for your leadership in always making sure that we have the best of presenters and of topics. We've covered a really wide range of topics in the Cameroon Town Hall for healthcare professionals, and we are looking forward to still get into those areas that we have not gotten into. If you are an expert and you think you can present to the Town Hall in an area that is important as far as strengthening the healthcare system in Cameroon is concerned, you're always welcome to send your emails to myself, Mono, or to Dr. Brian Tegomo, so we will always be able to respond to you. We have Kenji Obadi. I know you are also very passionate about this topic, and we've had a lot of background conversation around this topic. Let me hear your thoughts about the importance of this the importance of this topic today. Hi, Kenji. Dr. Kenji Obadi.
Hi, Elvis. Hi, everybody. Thanks. I'm on duty today, so I'm just joining from the office. Blood transfusion, as you know, is a very, very delicate topic, and it's something that is very dear to my heart. I'm very happy that today we have Simon, who is one of the leading experts in this field, to just stain a picture as to the situation in Cameroon. So I'm looking so forward to the talk today. Thanks, everybody.
Yeah, thank you very much, Dr. Kenji. Certainly, it's going to be an interesting topic. Before we get to the topic of today, we just wanted you to know that our presenter is a very humble person. He would not want a long presentation of who he is, but just to know that Dr. Simon Njoya is a very passionate professional, public health professional in the Northwest region, and he is heading the blood transfusion program in the entire region. And so he's very versed with the day-to-day activities when it comes to the challenges of blood transfusion. By training, he went to the University of Njoya and had so many certifications after his bachelor's degree. He's a lab scientist. He did microbiology in the University of Njoya. He's been a lab scientist and done so many other work around, hepatitis B and blood transfusion and all the different infectious diseases that are important in the blood transfusion unit. So I think he has a really broad idea, not just within the area of blood transfusion, but also within the space of public health and the infectious disease. So we are so happy to have you today, Simon, and thank you for accepting to present this topic on a very short notice. And I think we'll be very happy to get your presentation. Please, if you have questions, you keep your questions till the end of the presentation. Then we will take your questions, and we want this to be a very interactive session as much as possible. So over to you, Simon.
So much. I wish to thank you for giving me this opportunity to present on blood transfusion in Cameroon, particularly in the Northwest region. This is like a big privilege to me, but I'm going to try to be as brief as possible on the major things that my presentation will give you a true picture of what we are going through in the Northwest region. Presenting today, particularly with respect to the National Blood Transfusion Service. I don't know, are you getting me clearly? Hello?
We are getting you, and we're waiting for you to share your screen so we can be able to. You have the opportunity to share your screen now with us, so feel free to do so.
And if the network, I know the network in Cameroon can be bad, you can always turn off your video. It would improve the quality of your sound.
Yeah.
Are you getting my screen? Are you seeing my screen?
Yes, we can see your screen.
Representing the National Blood Transfusion Service. National Blood Transfusion Service is an institution, it's an overall institution that is the sole administrator for blood transfusion in the nation. It was created in 2003 by law, and by 2019, a decree was passed that put into function, it started like a program and ended up like a service under the National Blood Transfusion is to make sure that we can provide blood that is safe in good quantity and whenever and wherever it is needed. With the from 2019 to 2022, transfusion is supposed to go in to the nation, and for 2022, they deployed the first regional teams. I was privileged enough to pioneer the Northwest region, and these regional teams were dedicated to communicate for the National Blood Transfusion Service, to represent its authority at the level of the region, to do a cartographical representation of all the blood actors that are involved in the transfusion chain, and to make sure that blood is available, safe, and wherever it is needed. So we collaborate, our mission began with identifying actors and collaborating with them, getting into the fabric of the public health system, into the administration. We tried as much as possible to represent our mandate as the unique authority for blood transfusion. But mapping out this transfusion was our main mission. But we, as the National Blood Transfusion, though we are responsible every issue concerning transfusion, we did not come to just take over the transfusion service. We understood that running into the fabric of the district health service. I'll give you a perspective of the district health service. Right, habilitated.
Simon, unless that it's only on my end, I wanted to. Sorry to interrupt you. Sorry to interrupt you. I don't know if it's only on my end. Let me find out with the other moderators, Brian, and let me find out. Are you getting him clearly? Because I think he's saying.
Can I continue?
Just wait. We want to be sure that we can do something to make your presentation really. We are having challenges getting you clearly because it's breaking, and I know it could be network. Is there anything you could do from your end to make your network better? It's a very important presentation. We don't want to miss the things you're saying, which are really crucial. Is there anything you can do at your end? Maybe some bandwidth, increasing of bandwidth, maybe some data. Is there anything you can do to make your network better?
Swap the data. I don't know if it's possible for you to get me. I've stopped the video. Is it possible for you to get me? Are you getting me clearly now?
Yeah, we hear you now. I hope it would be able to continue like that. So let's give it a try again.
Presenting a National Blood Transfusion Service that began by law in 2003 and a decree was passed in 2019, which put in place the National Blood Transfusion Service, or what you call CNTS. It's a nationwide authority responsible for the availability, the accessibility of quality blood products. With this mandate, the regional teams have been deployed, and I was privileged enough to be part of the first to pioneer the regional service in the Northwest region. Our representation was to communicate on behalf of the National Blood Transfusion Service, to promote ethical blood donation, to map local transfusion actors the cartographical representation of all the various transfusion actors, and to do a monitoring and evaluation of blood bank activities. This has been a very challenging situation. This has been a very challenging task, but our dedication and our persuasiveness and commitment has helped us to integrate into the regional health structures and public administration, and has helped us to carry on with the mandate that has been handed over to the National Blood Transfusion Service. We are a structure directly under the administration of the public health ministry, and we are in charge of every operation regarding transfusion medicine in the country. Now, many people in the country do not know that there is a law governing transfusion. Many people do not know that there is a decree that are governing transfusion, even the transfusion actors. I was surprised that when I did first monitoring and evaluation at the region, many people were unaware of this, so I had to print out these laws and give it to them, distribute it to them, just to reinforce the authority of the National Blood Transfusion Service. Are you getting me clearly?
Yes, it has been better all this while. You can continue.
So, but when today, I would really like to talk about the challenges and opportunities that we face with respect to blood transfusion in Cameroon. My name is Njoya. I'm the regional chief for transfusion for the Northwest region. And I hope that the message I bring forth today will help you to shape your perspective as to how transfusion is being carried out and the challenges, not only challenges, but opportunities that we can pull out of these challenges, and how together we can make the transfusion sector better. So today we stand at a pivotal moment in Cameroon healthcare journey, where we are particularly concerned with transfusion service to regard critical issues which address appropriately can save countless lives. Cameroon currently needs a lot of blood, like you mentioned, 400,000 pounds, and this blood need is really unmet. So far, we are just at 26% coverage rate. Efforts are ongoing to reduce replacement donations or to convert replacement donors to voluntary and regular non-remunerated donors to improve the availability of blood products in health facilities. Now, these efforts are not enough, but nonetheless, there is something on the ground that is going. You will bear with me that it has changed. Like you mentioned, it is dropping from last year. The data that you read out, you realize that there was a drop in the total transfusion that we experienced this year. But I will try to shed more light why you are seeing this kind of drop. It's not necessarily due to the fact that people are not donating, but there are a lot of challenges that interplay and give false data. I would say false data because some of the data that we ought to normally capture, we miss a lot on this data. And so the statistics you presented might or might not be true. So to focus today, we're talking about changing blood transfusion perspective and the perceptions around blood transfusion, a unified donor database for transfusion, reviewing non-financial medical incentives and fidelity programs, addressing diagnostic gaps, and enhancing blood safety. Well, these are the topics that I think are really interesting. When you come to Cameroon, you mentioned in your introductory statement, we do have a lot of myths, misconceptions, and misunderstanding when it comes to blood, and these actually limits the time and life-saving interventions that medical health professionals could offer to patients whose life hangs on the balance. But Cameroon being a country with a multicultural base with about 280 ethnicity, this is highly expected. Question is, when you do talk to people and you do educate them appropriately, the turnouts for transfusion are usually very high. We work with civil society organizations, and most of the times when we do interventions, say in schools or churches, our turnout is usually above 70 pounds for one intervention. Now, where exactly is the missing link between people voluntarily donating and our blood banks running dry? I think the missing link here is in keeping sections, keeping what transfusion is. That's the missing link is in information. When the right information is given to people, timely enough, and when it is given in the way they understand and by someone they trust, then it is easier to get a high turnout for transfusion. So this is the reason why I think a comprehensive educational campaign, which will not only provide accurate information, but also engage communities in open dialogue and address their fears and concerns. It's a very important aspect that we should consider in our transfusion medicine. How can we do this? We have to involve civil society organizations and blood donor associations. Here in Cameroon, here in the Northwest region, I do have 187 civil society organizations that I work with and 8 blood donor associations. Now, not all these civil society organizations have for mission blood transfusion, but we are in a forum wherein when we do have sensitization, we get them involved, we get them motivated to partake in the transfusion, and they galvanize support, they galvanize their close relatives and friends and well-wishers to partake. This is the reason why I want to emphasize that the dialogue between future donors really needs to be addressed by someone that they have confidence in. It is easier for someone to give you a bottle of beer than for the person to give you blood. But it is equally easier for someone to give you blood when they trust who is requesting their blood from. That is the reason why blood donor associations are very, very important in and have been playing a very pivotal role in our mission here in the region. I'll give you 2 examples. When it comes to when we take the Matum area, we have the Humanity Helping Hands that spans the entire region, irrespective of the crisis, and they have foot soldiers that they do mobilization for the regional hospital annex in Cambe. And they do have a donor pool that they activate each time there is a need for blood donation. When it comes to the urban areas, for instance, we do have the My Kidney, My Life Foundation that helps a lot when it comes to mobilization. We have Safe Blood for Africa. We have One Track that we do use. We partner with these organizations has been a lot easier. Why? Because at the urban areas, for instance, most of them are students. It is easier for them to talk to their peers or to get their peers mobilized for transfusion. In the rural areas, the community-based organization do speak the local language. It is easier for them to translate our messages into their local languages and talk to the various schools, churches, and educational program and educational systems for them to mobilize donors that we desperately need. So my call to action and why exactly I am partaking in this program today is to take you to participate actively in this initiative, support research efforts that will provide the data needed to optimize our blood transfusion service here in the nation. These are some of the main things which affect and plagues our systems. Another very important aspect that we will have to look at, enhancing blood donation practice in Cameroon through a unified donor registry. I think this is the pivotal point that we are yet to explore. When we were deployed to the region, we noticed that there was a lot of unethical donor remuneration encouraged by client considerations. There was limited sharing of real-time data on available blood stock at the level of health facilities. There was limited connectivity and collaboration between blood banks as well as health facilities with regards to serving patients. All of this limited response time, as well as increased the amount of blood products that either got bad or expired or were not even available for the patient at the time they needed it. Most of these problems that you do see right now were addressed in efforts that we did in order to mobilize donors. We talked to so many blood banks. We did a speaking analysis. We tried as much as possible to link blood banks together, and we tried as much as possible to create donor groups. I will give you a typical example here. There is a group we run for the negative blood group types that each time we do have a situation where someone is negative, for instance, O negative and needs blood, we can tap into that database and try as much as possible to rally donors to save the life of the patient. But the problem is we kept doing that for over a year. And December last year, some of the donors did rally up and ask us, we keep donating blood for you, and what exactly can the hospital do for us? What exactly do we gain when we donate blood? Apart from the regular things that we will tell them about the advantages of donating, that is, you stay healthy, you rejuvenate your cells, and so on. They are regular donors, and we have been sending the same message to them. So, and sometimes donor mobility is another issue that being used often. So you call the donor and you plead with the donor to come and donate. It tells you that I'm in Douala, I cannot donate right now. Why? They don't have the incentive to donate. An active national blood donor registry with real-time mobile blood reserve response group is something that can really save so many lives. How do we envisage this kind of initiative? We want to be able to test at the level of each community, at the level of each locality and create a donor pool. We want to be able to come together, bring these donors together, especially in our region where we are plagued with a crisis and shortage of electricity. There is no guarantee that collecting blood all the time or going out for campaign all the time might necessarily meet the needs that the hospital really requires. So we want to create donor pools. And to do this, we will need an active testing of the population. It will be interesting to know exactly the distribution of blood groups in the population to get incentive programs that will bring people together and make sure that they can donate and save lives. So for us to do that, one of the major things I would really be advocating for here is the creation of a real-time national blood donor registry to support policies that promote ethical donation. I am happy to be talking to specialists here that I hope to see exactly how you people run your own service. But for most part, we have initiated a lot of top programs to bring in donors. And to do that, we came out with 3 main programs for this donor registry. We had these are just initiatives that we are still working on. We came out with an incubation initiative, a maturation initiative, and an advocacy initiative. An incubation initiative we wanted to in place a testing facility that is going to target age groups within 7 to 17 years old. Now, these are young adults that, as each year passes on, they mature into donors. We are able to, within this incubation phase, what we give as programs, I will share with you some of these documents that we have been working, some of the programs we have been doing. What we do with them is that we share with them health information, preventive health care information, vaccination, sexual health, and reproductive health care information that helps to keep them safe. And then we share with them, we demystify what donation is all about to them. Then we have the maturation phase, which spans from 18 right up to 37. Within this group of people, we target basically incentives. Incentives for donation, while at the regional hospital, volunteering, acting as a volunteer at the regional hospital over 8 years. We began a vaccination program against hepatitis B, and we targeted just blood donors. We even introduced the program at the level of blood bank because we wanted to maintain the cold chain of vaccine, and we used monovalent vaccine for that. Within this time, I noticed that most of the donors that came in claiming to have been vaccinated were not yet immunized. So some of the donors actually came back positive for hepatitis. Now, we cannot say for sure, given the hemovigilance system, which we are still working on, we cannot say for sure where exactly and how exactly they got the hepatitis. So that is why, that was one of the points that I wanted to protect the donors. That is why I initiated that program. Within that program, we had at least a 95% immunization rate because we got the donors engaged into testing, and we got the donors, thereafter testing, we got the donors to do the immunization test to make sure that the titers were above 10 international units. That means they were immunized. And within that time, these donors, for the mere fact that we gave them this privilege, were addicted to donate blood. Every time they volunteered, they came without reminders. They came without reminders just to save lives. Just because of these incentives, some of them brought even their family members, their children for vaccination. Then that was just for the maturation phase. When we go to the advocacy phase, so there were donors there were people that were old enough, not that's above 65 years old, they could not donate. And there were people that for some reason or another, they could not donate at the given time they would call. So we brought into the program an advocacy phase where we were proposing that they could support blood drives. For this, it was quite easy at the beginning because their support, what was requested from them was just to mobilize people that could donate. So we did through that. We had associations that came to donate. We had Njangi houses that came to donate. We had churches that came to donate. These advocates, these people who acted as advocates for blood donation really helped us to drop the gap, to meet the gap of the limited blood that we had at the level of blood banks. Another challenge that we face particularly is enhancing blood donation through non-financial medical incentives and fidelity programs. I have just spoken to you about some of the things that we noticed when we came to the region. It is frontal one-time blood donors. I do hold the data which you will see recent shortly, and the high rate of unmotivated population. No donor incubation programs. That was the reason why I said we had to bring in most of these programs in order to be able to meet the need or reduce the poor loyal donor base that we met at the level of the region. These disgruntled one-time blood donors were the way we used to address this problem was to do a situational analysis at the level of the blood banks. Whereas the situational analysis focused on both staff as well as equipment, as well as consumables and everything. I will share the document with you, and you'll be able to see. So some of them, sometimes we had to visit the major blood banks in order to tell staff how to receive, how to treat blood donors, and that came in as a result of calls that when you call a donor to come and donate, and donor tells you that no, I cannot go to the regional hospital. I was there one time, or I cannot go to this. I was there one time and one staff talked to me very briefly. So we had to address some of the things through training. And it was a voluntary, that means it was an out-of-pocket sponsor training. We had to move there, talk to the whole meeting, attend the monthly meetings, talk to them about attitudes whenever we're doing monitoring and evaluation. The high rate of the unmotivated population, like I mentioned earlier, is as a result of a lack of information and who brings forth the information and how the information is being given to the population. When during the World Sickle Cell Day on the 19th of June, we did have a youth outreach program wherein we had to talk to young adults about donation. The response rate was very high. Why? Because they saw a need to donate. We told them the advantage, and most of them had never heard. We targeted the Bororo community, and we had donors from the Bororo community People, this is a unique community because they mostly are based on instructions. So sometimes the kind of message that is given is very, very important. So there is no donor incubation program. Like I mentioned to you, this is just an initiative that we are beginning, and we don't really have the resources to put forth this particular aspect. And we do hope that we can bring in a lot of change with respect to that. So non-financial medical incentives and fidelity programs play an essential role in fostering continuous voluntary blood donation. How? Offering health checkups, for instance, to the maturation phase of the program. Priority medical services. The National Blood Transfusion Service actually on World Blood Donor Day offer certifications as well as donor cards, but you cannot unify the priority medical services that are offered at individual healthcare services. For instance, you can go to the regional hospital and you have a 50% discount on all your medical bills. But when you go to probably another place, they'll tell you that no, they offer 10%, or they tell you that they do recognize them. These are some of the things that we have to work to unify the recognition program. And to a good donor database will identify anywhere they are in the nation. So my call to you today is to champion the implementation of these incentive programs within our institutions and encourage donors as well as future generations of donors to participate in blood donation. I would like to address one of the elephants in the room, which is actually the diagnostic gap and enforcing blood safety in Cameroon. Upon a situational analysis that we conducted, we realized that those inadequate safety levels, limited quality blood products, and then the recovery cost levied on clients was not uniform. This led to insufficient diagnostic capabilities for blood qualification. I'll explain each of these points very briefly. When you take a country like Senegal, a pint of blood costs 3,000. But when you come to Cameroon, the pint of blood varies from 17,500 right up to 50,000, a pint of blood. So, and sometimes when you go to some institution, you have to provide 2 donors. Sometimes you have to provide 1. Sometimes they just tell you that just give 50,000 and they'll give you the blood. So you cannot, it is not unified. The national plan is still being rolled out to determine exactly how much the pint of blood will be. But since the National Blood Transfusion Service is not taking over the transfusion medicine as of now, we have the mandate to do that in the future when we'll be capacitated, when we'll be given all what we desire to roll out our strategic plan. But for now, a lot of health institutions determine their pricing on blood products, which is supposed to normally be a recovery cost. But sometimes it is heavy on the patient. And you know, in Cameroon, most healthcare services are paid out of pocket. Then the limited quality in blood products is really geared by the non-unified algorithm in testing. That means you might go to PMI and they're using ACON to test for hepatitis. You go to the regional hospital, they're using 1/4. You go to Bingo, they're using probably another name for a test. Most of these tests might not be verified or validated. It is absolutely important for us to consider unifying an algorithm when it comes to testing for blood in order to ensure safety levels to blood products. That is one of the major things I would like to say and request from you is to support funding initiative, which will push for the adoption of advanced diagnostic technologies in our blood screening process. For instance, we can move to molecular testing, molecular diagnostic testing. That is going to be a good way in order to be sure of the products that we are taking out to patients whose lives are on the balance. One of the ways in which we can do this due to financial constraint is to pool funds to afford verified standardized algorithms, approve tests, as well as transition to molecular testing, diagnostic reserve kits. You would not believe in Cameroon, sometimes we run out of testing kits. Let's take an example of determine. Sometimes you might be looking for determine for HIV testing and you might not be able to see a kit for it. Consumables. Sometimes we run out, we can go for like 2-3 months without enough blood bags. We have to shuffle. That is why the regional representative is responsible for interacting with the different blood banks such that you can take from here and give to the person that doesn't have. So there are a lot of stockouts. So my call equally is to make sure that we could make consumable backups available for transfusion services. Now I'm going to explain something with respect to this data sheet. It might look cumbersome, but we have about 15 blood banks in the region. You can see from the barcodes, the long barcodes to the left, that we do have at least 3 major transfusion centers that have high volumes. But what I want to put this graph side by side so that you could see. Within the first year, this is the quarterly report on the left for this year. This is the entire report on the right for last year. When you look at the mean number of transfusions that were done for the first quarter of this year, we ranged within a mean of about 400, let's say 300 or something, let's say. When you come down to the previous year, we ranged within a mean of about 500. Now, this disparity in results that you see is not due to, I go back to your first intervention. It's not necessarily due to the fact that transfusion needs really dropped this year. No, it's that many centers that used to partake and donate their information regularly when we first came into the region and they were enthusiastic. Some of them are not transmitting their data anymore. They are not transmitting the data anymore. They will complain of connectivity. They will complain of lack of data, communication query, which we used to send that if the waters run dry as the seasons change. As I earlier mentioned, we are limited on funds, and most of these funds are out of pockets. Even the Director General funds some of these projects out of pockets, as well as the regional representatives equally. So this is the transfusion just for the Northwest region. And this is to show you the interplay of the data we are missing when it comes to the different blood banks. To change this particular situation, it will be important for us to have at least an electronic device that will capture this data in real time and work at each blood bank and unify this data in order to be able to say confidently that this is the baseline of what we need for transfusion for this for this region each year. And with that, it's going to give us a perspective plan. This data was developed by volunteers, that IT volunteers and data analysts. I work with 2 at the regions right now. And I'm hoping that head person is going to join me because he's actually trying to offer solution with respect to donor database. When you look at this curve, what I really want you to see is the age groups that are donating. The age groups that are donating regularly fall within the 18 to 27 years and mainly males. The first-time donors are really hard compared to the regular donors. So what we want to do here is that we want to be able to know by tracking this kind of data where to concentrate our sensitization campaign and the demography to concentrate on so that we can make them faithful to the attitude of donation. That is the reason why I presented this data. You might have time to go through. The next thing here, I want you to concentrate on 2 things. We have repeated donors that exist that are here, and first-time donors. If you notice, our repeated donors are lower than our first-time donors. This is a problem.
Simon, did we miss you? We can't hear you if you're speaking. Yeah, so I think we may have lost Simon. Let's just give it a few minutes, and if it doesn't, then we'll try to discuss a little bit more about. I know he's currently dialing in from Cameroon, and sometimes the internet connectivity is not always optimal. It's not always the best. So, but I think he's presenting some really important, critical challenges. I was really blown away with some of the data that he showed in those last 2 slides. I think those are really reminiscent of the challenges with optimizing blood transfusion in Cameroon, and really mirrors some of the trends in other countries as well. So, and I'm also very curious how other countries, and I'm really interested, Dr. Mona, about how the US typically handles this. How do you ensure that you have, one of the things that you really mentioned was retention of voluntary donors really over time, and particularly those who are not remunerated for it. How do you ensure that kind of constant supply? So I think he's highlighted a lot of questions, and I'm really hopeful that we will have a very deep discussion after his presentation, Q&A, so that we can maybe brainstorm together a little bit more about some of these issues. Simon, are you back?
Yeah, so while waiting on Simon to join us, and Brian, as you said, this has been a very insightful presentation, going back to really tell us the data that we have back at home and what is happening. So I think Simon is back, so let's give him a chance to finish.
Yeah, Simon, over to you, please. If you're speaking, you're still muted, so try to unmute yourself, and then we can hear you. Simon, you're still muted.
Yeah, so Brian, as US, your questions about what is done here in the US is we've had a culture in the US for donating. States do have different levels of difficulties depending on each state and how much capacity they have and financing. I just moved from New York to Albuquerque, New Mexico, and there's a whole lot of a difference, but we do have access to blood, which is something which is very important. We don't do or require families to donate. We rely a lot more on donor registries. We rely a lot more on retained donors, and we encourage donors to donate as soon as possible and whenever they feel like. So there is a culture of both donating blood, which is the first kind of transplant you can ever have, but there is a culture of donating blood, and there is a culture also of donating organs. And once you're doing your ID card, you're also required to say if you love to be an organ donor, and also you're encouraged to donate blood. So where I find the difference is that back in Africa, we still do a lot of whole blood donation, which we have to learn to get out of whole blood donation, because the technologies to do different blood donor components is not very complex. To be able to donate plasma and to be able to donate platelets and also donate red blood cells, which back home we have difficulties in managing cancer patients and other kinds of hematological complications as a result of that. So I think Simon is back. Let's listen to Simon to finish his presentation. We're just chatting while your network had a little problem, Simon.
Thank you so much. Are you getting me clearly now?
Yes, we can.
I'm sorry, our connection here, I have about 3 different connections I'm trying to swap so that I shouldn't disappoint you. But let's just move on. So we're talking about donor incentive programs that we put in place. We did have an activity last year with the youth outreach program. Here you see where we produced blood cards that carried the blood group of the patient and the atrial electrophoresis of the patient. This was with the donor incubation phase program that we started, that we pilot. We ran a pilot on, and we noticed an incidence of about 19% of the of AS that were present. We educated them on life changing choices that they ought to make in order to limit the future demand of blood if they should produce SS children. This kind of grassroots initiatives are something, some of the initiatives we have been putting in place in the region in order to educate people, not only about blood, but with a holistic approach towards transfusion medicine in general. The picture you see on your right is an education for adolescents and young adults, which we carried out in the maturation phase, just to give them a notion of what basic hematology is all about. And that is, in a nutshell, some of the things that we did. So in order to conclude, enhancing blood transfusion practice in Cameroon requires our collective efforts. Beyond educating our community and advocating for ethical practice, implementing incentive programs, establishing a donor registry, real-time database, and addressing diagnostic gaps, we can make a profound impact on our healthcare system. Donating blood is an act of solidarity, and I think you have extended the solidarity by me joining your effort, and together I think we can save lives. The take-home message that I want to provide to you today is to join us in advancing the blood transfusion service in Cameroon. Your pool funding, your advocacy, your drive can drive essential reforms, ensuring safe, ethical, and efficient blood donation practice. Together, we can save lives. When you look at some of the things that we have been doing, 90% of these things that we have been doing are initiatives that we set up. We need your support in order to sustain. We need your support in order to be able to sustain such initiative. For instance, I will share with you, this is a bank that we produce after a research on all the various double materials. Within this band, the outer cover was supposed to carry the ministry, our logo. Within it, you needed to be at the internal part of the band, your blood group was represented, and your HB electrophoresis type. In a case of an emergency, and in a case where you meet a friend, it is easy for you to convince your pair with just wearing this cultural health status identifier. That's how we call it. This is an initiative we propose to the National Blood Transfusion Service, and we propose to some partners to help us to generate it, but it's still in the making. Let me put it that way. So during our last month, we did have
Yeah, I think Elvis, we lost you. Sometimes it helps if you switch off your video just briefly. So sometimes it helps with the connection. Yeah, so I think we've lost Simon once again. Can you hear us?
I can hear you.
Okay, great.
I was just concluding on my slide and telling you that we have introduced a lot of initiative, and we are pleading and we are happy with your support by giving us this platform that we could share in our practices and in our initiatives that we are putting in place in order to promote blood donation in the nation. So over to you, and I'll be happy if you verify.
Yeah. Thanks a lot. Thanks a lot, Simon, for that really helpful and really elaborative presentation. I think it was really great, and we do understand that you're currently in the Northwest region, and the connection is sometimes not always optimal. But thanks a lot for providing us a really deep presentation on the real challenges on blood transfusion in Cameroon. I just wanted to maybe give Dr. Mono maybe a chance to. We really would love to hear some of your take on some of the way you've seen transfusion medicine being practiced in the United States, and some things that you think we can possibly mirror from what's done well. We certainly have lots of challenges. I think he highlighted some of the issues with diagnostics and molecular diagnostics for transfusion, transmissible infections and things like that. But I really would like to hear your take on what you've seen and some of the things that you how different that is from the way it's being done in Cameroon. Dr. Mona.
Well, thank you, Brian. I will try to be as brief as possible. I think Simon is an example of how Cameroon should move forward. Someone who is forward-thinking, who is at the verge of really changing. Every sector in Cameroon needs improvement, but we need to look at the things we're doing well. And you can see that since creating this structure, they have been able to kind of coordinate things. But from my observation and discussing, there's a lot of lack of financing. And also at the level of, let's say, the whole healthcare system understanding the importance of transfusion medicine in order to improve what we're doing. So, and integrating it into other services, especially infectious disease and the PEV, which is National Vaccination Program, can really help out because a lot of those secondary infections can be prevented. As he told us, we have issues with testing and standardized testing. In all these centers, there are people who are still hepatitis. These are things we don't talk about, who still donate because of the kind of test that goes around. So safety becomes a priority. Here in the US, most transfusion is actually centralized, and there are other services that do help us, but they are very well equipped most of the time. Blood bank medicine is a division of two main specialists. There is the pathologist who subspecializes in blood bank medicine, and there is the oncologist and hematologist who uses blood products a lot. And everyone uses blood products, and there's a lot of testing that we do. Apart from the ABO and race-use testing, we tend to do a lot of other testing, especially for sickle cell patients and patients who require a lot of transfusion. We hardly give whole blood anymore. And I know 90 to more than 99% of all the blood we give back home in Cameroon is whole blood. Whole blood has its issues. We do actually give packed red blood cells. We're able to transfuse platelets, which that becomes a big issue when you're dealing with hematological cancers and children and other people with ITP and other things with platelet issues that you cannot transfuse platelets. We do transfuse plasma, and these are things that are easy to separate. We do transfuse cryoprecipitates. Rarely do we do transfuse white cells, but it's something we talk about. Risk of transfusion is a big part of medicine, and bloodless medicine is something that is being practiced in some areas. So really the indications for transfusions are things that we can always talk about as we'll discuss. I don't want to spend time on that. But apheresis machines are things I've not understood. I'm just giving a cry out to the diaspora also. If we can get access, every region has an apheresis machine where we can place patients on an apheresis machine and be able to actually get different components directly. While they're giving blood, we're able to separate them into multiple other components. And also we should be able to train our physicians, nurse practitioners, and those who work in the lab for us not to waste products, because I know back home, we do collect red blood cells, pack red blood cells, but at times we waste the plasma because we don't know what to do with it. And testing is also very important. So standardized testing is important. Here in the US, everyone who donates blood, we do ABO and race-use testing. We do antibody screening. We do excessive screening in cases where we want to transfuse those who are already having antibodies that we know about. We register those patients, especially sickle cell patients. At times, we even do an HLA match, especially for women who are pregnant. We do hepatitis, A, B, and C. We do HIV. We do syphilis. We also do Western Nile. I think we do Western Nile. We also do Trypanosoma cruzi. We do Babesia. But there are other things that are tested. So, Brian, transfusion medicine can be a very complex part of medicine, but we need to put infrastructures. We need people like Simon who are going to lead the way. Because I'll tell you that in order for you to get these blood products at times, it's not very complicated. If you get whole blood, and I want to get red blood cells and platelets, I just need to do a soft spin. Meaning that's just I just need to do a soft spin and I'll be able to separate platelet-rich plasma from red blood cells. Then if I take the platelets and I do a hard spin on it, it's going to give me platelets which is poor in plasma and will give me platelet concentrates. So you can use algorithms like that. And if I thaw or I freeze it for 8 hours, I'll be able to get what you call FFP. And then after thawing it, you will be able to separate cryoprecipitate. These are simple algorithms that you can do. If you take whole blood and you do a fast hard spin on it, just spin it hardly, you will get red blood cells and you differentiate and get poor platelet with plasma, and then you can get a Buffy code. So these are things that you need just simple training for laboratory, those who work in blood bank, to be able to help you separate these components that you can use in the future. So we need more training. We need people like Simon and Brian. I'll leave it there so that we can talk about questions and answers, and we can really talk about how we can get to improve blood bank medicine in Cameroon. Safety is priority. Getting to have retained donors is also very important. But here in the US, we have been doing this for many years. I just met the system. I trained in Cameroon. And I think there are a lot of things we can learn from the US, from Europe, and there are also innovations that we can do locally, because local problems require local solutions.
Yeah, thanks a lot, Mono. I think you mentioned a lot in that, and really thanks a lot for sharing that perspective from Cameroon. One of the things I heard you say is how the US screens for different sets of diseases. You mentioned Babesia and West Nile and probably others, and I think Simon only referenced hepatitis and HIV. So. Simon, I'm kind of curious about the current epidemic. Is there surveillance? Do we know what the current trends or epidemiology is of transfusion transmissible infection in that sense? I know you didn't really touch on that, but I'm curious if that's a metric that's being followed in this surveillance mechanism that you have in the Northwest.
I think Simon is muted.
And we do have data that checks on the transfusion transmissible infection. Are you getting me?
Yeah, I think we're having some challenges
Hello?
with getting you. Yeah, you can try to switch off your video just briefly. Maybe it might help with sometimes it helps with the
Can you get me?
connection. Yeah, we can hear you, but your voice is breaking. So I think it might be helpful to turn off your video, and then we can try that way and see how it looks.
Can you get me now?
Yes.
Okay. No, transmissible infection. Those are some things that we do, but I will basically say we concentrate on hepatitis B, hepatitis C, HIV, syphilis, and that's about it. We don't just. I heard Dr. Mono mentioning a lot of things that are being screened. At first, we were doing malaria, but we dropped that. As for the last 2 years, we've not been doing that. So we do blood grouping, and that's about what we do. We don't even do the HB electrophoresis for the patients. We don't do systematic HB electrophoresis for patients, which is something I've been advocating for, so that we could be able to help patients who need, prevent donation of sickle cell to patients that are already sickle cell disease patient. So we do not do that. We do not do so many of the things Dr. Mono mentioned. We concentrate just on the basics. We do the blood grouping, and we use 2 methods. We use the Vincent and the Simoni method to do that.
Yeah, thanks a lot, Simon. And the reason why I just brought that up is just that I noticed that in the audience we have someone who is really great in molecular diagnostics, and that's really Dr. Kenji, and I think that's an area that he could definitely help in that sense. And also notice in the audience that we're really again really honored to have Dr. Bogoman, who is an infectious disease physician here as well. So I think that it'll be really great to hear some perspectives on transfusion, really the surveillance of transfusion transmissible infections in that sense, which I think is also critically important. There are some questions that came in the chat, and I also really want to encourage others, if you have other questions, you can drop those in the chat, and then we will try to address those, or you can just use the raise hand function, and you can also ask your question that way. I do see that Dr. Charles Awasum's hand is up, so please, Dr. Awasum, please.
Good evening, everybody. Yes. Without really taking much of your time, I worked as a surgeon in Cameroon, in Limbe and Bamenda for 30 years. I was director of the regional hospital. I'm very glad to see my young man, Ken Former, who came in as a young GP and who is now a very big oncologist in the United States. And as director, I was involved in 2013 in trying to set up a national blood transfusion service. And the regional hospital, Bamenda, as you see in the statistics, has a very robust blood transfusion service. I sympathize very much with Dr. Njoya, who is the national regional coordinator, who is actually just sitting as a layer over a very, very, very serious problem about blood transfusion in Cameroon. And I just want us to go back to very, very simple issues. When you talk about the blood bank, you're saying that we want to create a system where blood is kept, properly tested, and available for distribution all over the region at all times. And to be able to save your money in a bank or whatever you save in a bank, there must be some element of credibility. And we're talking about the cost of blood transfusion. I went around, set up a robust system. We went to schools, we went to churches collecting blood. And at the end of the day, they said, but doctor, we give you blood for free, but you sell blood. And it is difficult for me to explain that you have to do tests for 35,000 francs before the blood can be rendered safe. And so then why do you come and collect our blood and we have to pay 35,000 francs? And the point I'm trying to make, if we have an HIV program, national HIV program, and we cannot provide credible HIV testing in the blood banks, unprotected sex will give you about a 2% of picking up HIV, but unsafe blood is 100%. We're running a hepatitis program and we cannot provide hepatitis kits free for blood testing in the blood bank and all of those kind of things. A national program, yeah, Dr. Njoya, I feel sorry for you because you have been put into a national program which is running as a program. And like every other national program in Cameroon, it is just a white elephant. I'm sorry to be able to say that. The issue of blood transfusion in Cameroon stares us in the face. It is not possible that you might be able to get a safe transfusion even in the regional hospital because test kits for safety are not available all the time. We need to address this simple problem. And also somebody comes and gives you blood. To be able to transform this blood into a safe package to be able to give requires a lot of money, which the person who has even donated will have to pay from pocket. And these are really very, 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 very fundamental issues. Before we start talking about like what Dr. Ken Former is talking about, component separation and all of those things, we have not crossed the first line. What is the issue? What do we call a blood bank? What is a blood bank? What is a blood bank? You know, it's a more fundamental question to me. Does the patient feel safe that they can come and give blood? And when he comes, you say, okay, you came and gave blood here last week, and therefore your relation needs blood, you will get blood again. We need to get down to very, 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 very fundamental issues. And so having run a blood bank, we go to a national meeting and I tell people that I provide sandwiches. Do you need a national program for someone to provide sandwiches to provide for blood donors? They're very simple things. And I praise Dr. Njoya for his effort, but I really don't envy him at all. Thank you.
Yeah, Dr. Awasum, thanks a lot. Thanks a lot for your remarks, and really thanks a lot for setting up the transfusion center at the regional hospital. From the data he presented, it looks like the regional hospital in Bamenda has one of the highest, at least, collections for safe blood in the region. So thanks a lot for your leadership in that, and also for your advocacy for for global health and really strengthening laboratory medicine capacity as well. So thanks a lot. It's really a great honor to have you among us today. I want to pass it on to Dr. Bogomati Tanji, please.
Hi, Brian. Thanks so much for the opportunity to speak. And as Dr. Awasum was speaking, I was just nodding my head because there's so many points that he raised that I think are so crucial and so important. I'll start my comments by sharing two anecdotes with the group. When I was a fifth-year medical student in Yaoundé, I remember while doing my rotation at the reference hospital in Yaoundé, one of our professors in CUS, whose name I would not call, but who is a hematologist and quite a leader in the field, had her mother-in-law hospitalized in the hospital in Hôpital Général. And her mother-in-law had a need for blood transfusion and had a really low hemoglobin. And this professor said, we'll figure out a way to raise her blood levels because I'm not going to allow her to get a transfusion because I don't trust the blood. And that was a professor of hematology who was a professor at the medical school. She did not trust the blood that was available in the transfusion bank at the reference hospital in Yaoundé many years ago when I did my medical training. The second anecdote, when I finished my medical training, I worked in La Quintini Hospital in Douala. And while working in that hospital, I was posted to the emergency department. That was where my focus was. So obviously working in the emergency department, you get a lot of road traffic accidents on the Douala-Yaoundé road that get brought with many patients that come in with trauma injuries, needing blood transfusions from blood loss. And there was a night where there was a really severe accident on that road, and we had about 20 people who were brought in through the emergency room. Lots of significant injuries, and obviously lots of family members who rushed to donate at the level of the blood bank. And so I went down to the blood bank because there was one patient who needed blood, and they had brought in 10 family members to test. At that time, the HIV testing for the blood that was offered was 2 rapid tests. So they would run 2 determined tests on the blood that had been collected. And that was the HIV testing that was done on the blood. And then they also ran a hepatitis B and a hepatitis C serology. One family brought in about 12 donors. And I was curious because at that time I knew already that I was very interested in infectious diseases. That was what I was committing my career to do. So I was curious to know how many of those donors that night actually were able to donate blood that was usable. And so I went down, I talked with the lab director and just kind of getting the statistics on how much of those blood units actually tested positive for something. And they had collected about, if I recall correctly, they had collected about 26 units of blood that night. And between screening for hepatitis C, hepatitis B, and HIV, only about 6 units were usable. All the rest had to be discarded because they tested positive for one of those infectious diseases. And I would add, not an anecdote, but I would add to say that the estimated prevalence of hepatitis B in Cameroon, depending on where you are in the country, is anywhere between 6% to 10%. And the prevalence for hepatitis C hovers between 5 and 6% of the population. So screening for infectious diseases and making sure that the quality of the blood products are actually safe is still the most important component in ensuring the safety of transfusion in Cameroon. And if you don't have the ability to guarantee that the product that you're administering to people is safe, then that in itself also kind of dampens your ability to really provide that service to its full extent. I completely take Muna's point that transfusion technology has advanced to the point where there are very basic things that we can do to provide blood components, be it platelets, fresh frozen plasma, packed red blood cells, etc. But before we even arrive at separating blood to its individual components, I think that we must address the very basic question of safety from infectious diseases. And just to take the testing for HIV, really, the testing that is done in the US for HIV is not it's not even a fourth generation ELISA that can detect an infection within 10 days of an HIV infection. We do a PCR. It's basically you test for the viral load to actually shorten the window of detection to as narrow as possible. So if someone donated blood and they had acquired HIV 4 days ago, by the 5th day, their viral load should be undetectable. It should be detectable. So that is really the test that allows you to really minimize the risk. If you're doing a rapid diagnostic test like a detamine test, that could take up to 2 to 4 weeks to turn positive from the time of infection. So you really see that window exposes people to coming in contact with contaminated blood that can then result in them getting infected with HIV. Now, moving beyond HIV, when you think about hepatitis C, yes, we have effective treatments now for hepatitis C that effect cure by 98 to even 100%. But these treatments are not yet widely available in Cameroon. I know that the ministry recently significantly subsidize the cost of treatment for hepatitis C, but there's still the issue of identifying the people who have hepatitis C in order to be able to treat them, because we're not screening people enough and we're not identifying carriers enough to aggressively treat them. Then when you turn to hepatitis B, we do have a higher incidence, a prevalence of hepatitis B in Cameroon, because we have perinatal infection that is very common in West and Central Africa. Then you get the sexual transmission as well as the transmission through blood products. But as opposed to hepatitis C, hepatitis B doesn't have any treatment. Like right now, what you can use, there's some treatments that can offer. When I say no treatment, it doesn't have a cure. You can have antivirals that can make the disease to be not active by suppressing the viremia, but you can't eradicate the virus. Granted, we do have a vaccine, which is now in the National Immunization Program and has been in the program now for over 15 years. So we hope that in the future, we'll see the prevalence of hepatitis B continue to drop. I'll close my remarks by just kind of commenting, like I know Dr. Njoya mentioned the fact that they don't test for malaria, and Dr. Former mentioned the fact that in the US, we test for other things like West Nile virus as well as Babesia. There are additional tests that are recommended for screening of blood samples that would vary depending on the disease epidemiology of the region where the transfusion bank is established. For malaria, in a malaria endemic region, it doesn't generally make sense to screen every unit of blood for malaria for a couple of reasons, because most adults who live in a malaria endemic region have some degree of parasitemia. If you take people who are walking around in Bamenda or in Yaoundé or in Boya or anywhere in Cameroon, and you just sample them and you look for parasites, you will see some scant parasitemia that is not necessarily making them sick. But as opposed to hepatitis B or hepatitis C, malaria is treatable. And in an adult, if you're transfusing that blood to an adult, or it's unlikely that an adult living in an endemic region for malaria will get severely sick from the malaria to the point of dying off from the disease. In children, we obviously have to be more careful because it's a lot more severe. But the point being that even if someone developed a fever and malaria after getting their transfusion, there are medications that you can offer to treat them that will be curative. Other things like West Nile virus and Babesia do not circulate in our environment. So it doesn't make sense to screen for those because, again, we're balancing how much you spend on screening in order to be cost effective, to make that blood safe, and being able to deliver products that are safe. Things that I would think would make sense and should be incorporated in screening in our setting is things like running a syphilis test. Because again, syphilis, although it's treatable and curable, can also be an infection that has so many manifestations and can be latent for several years and cause tertiary manifestations with tertiary syphilis and things like that. But it's also treatable. So if you detect it, if you're not able to do the screening before you transfuse, then certainly if someone has had a transfusion, that should be something that their general practice physician should be thinking about doing, screening them for syphilis to make sure they did not contract it in the course of their transfusion. So these were my thoughts, and I really commend all the great work that you're doing. And all I can say is I wish you lots of courage, and let us know how best we can support that work, if it's through advocating or if it's through using our expertise in some way. Do not hesitate to reach out. Thanks.
Yeah, thank you so much, Dr. Titanji. I really appreciate the open invitation you've given to Simon. Thanks a lot for those really important comments. I really love those two anecdotes you gave, and I think, Dr. Mona, that it really highlights some of those fundamental challenges we discussed earlier about blood safety. And which I think Dr. Charles Awasum also mentioned as well. If we could at least address some of those critical fundamental challenges with blood safety before discussing about more advanced blood banking practices like what we have in the United States. So I just wanted to invite you, Dr. Mono, maybe to really look into what Dr. Bogoma just shared with us today, and also some comments on what Dr. Awasum shared. Over to you, Mono.
Yeah, I'm very happy Bogoma is here today. And also, I just want to use this opportunity to thank Dr. Awasum, who is like a father to me, and also has been a mentor for all these years, for the wonderful things he did while he devoted his time to Cameroon to train us as young doctors. And he's been an inspiration since when I was born, so to ever get into the medical field. So thank you. And it goes back to the basics, as they all said. And I would allow Simon to react to their what they said. I'm happy Kenji is here too to give us an insight. If you don't get your basics right, you can't even move forward to do advanced things. So we need to, first of all, make sure that blood that we're providing is safe. And we gain the confidence of both the physicians, the nurses, the laboratory technicians who work and deal with that blood, and then the patients. And they raised a very pertinent thing. Why should we collect blood free and then have people pay for it? Because we need to test that blood, but how do we get a national program where we can afford these things and make blood safe? So, Brian, that's my first reaction. I'm not going to go into the complex things that we do as hematologists because we don't even have the basics. So I think we should be able to encourage Simon and help his program advance as much as possible. Over.
Yeah, thanks, Mona, for those remarks. I just wanted to give Simon an opportunity to respond. I think you heard the comments from Dr. Charles Awasum and also some of the remarks that Dr. Bogoma Titanji made. I just wanted to give you a chance to respond if you have some comments. Simon.
Thank you so much. I have enormous respect for Dr. Awasum. He was the director when I was working at the TB lab. And he used to encourage us to go to school and study very hard. That was always on his speech. Make sure you go back to school. So I really, and the last comment he made is that he really pities me. He pities my condition. Well, my take on what was said is, I think my coming here today was to prop frugal solutions, not complex solutions. You cannot begin to compete with the level of the United States. No, we cannot begin to compete with the outer world and with the expertise that are available. That is why, for me, I think the basic is concentrating on, first of all, getting a coordination of our donors, a unified testing plan, and validated test, verified validated test, and move into molecular testing that is going to assure safety concerns. I did not get Dr. Watson clearly on so many things, but he mentioned something like sandwiches and what he offered to donors. Sad to say that for now, the transfusion service is still being run by the hospital, and most of those things are being borne by the hospital. So we really do not intervene in things like that, but we are supposed to be able to offer the basics when it comes to that. But financial constraints, like he mentioned, because he talked about financial constraints, right? For a program that is still tripping into its service, it's really quite early, and it's difficult for us to be able to bring that into perspective the right way we should. As for what Dr. Tanjip mentioned, it is I don't really have so many comments on that. She actually expressed the skepticism that most doctors who have in the healthcare system back here at home, even knowing exactly what it takes to screen the blood and the dysfunctionality when it comes to the algorithm of testing. So I think that this is something that as healthcare professionals we should come together and advocate. My major thing is to advocate particularly for the unified thing, a unified, validated, verified testing method that are going to guarantee safety, and then bringing together donors, advocating to bring together donors, as well as advocating to bring funding in order to sustain continuous promotion of blood donation. If you get into the science, you might be so disappointed with what you find on the field. It doesn't mean that nothing is improving. At least we're trying everything we can to improve on the situation so far. Thank you.
Yeah, thanks a lot, Simon, for those really great remarks as well. Just wanted to also add my voice to really thank Dr. Awasum for being here. Since everyone has thanked him, he's one of those who really inspired us. I remember back in the days, several years ago, when I was a student at Sacred College Mancon, he used to come and talk to us and really inspired us to work hard and pursue careers in medicine and healthcare. And I'm really grateful for everything that he's done and continues to do to advance medicine and global health as well. So thanks a lot for that, Dr. Awasum. I wanted to transition quickly to Dr. Kenji. Dr. Kenji is one of the laboratory leads at the Stanford University, and I think he has some great experience with molecular and clinical molecular diagnostics. So he did make some comments in the chat, which I thought was really important, but I also wanted to give him a chance to maybe speak into this aspect of molecular testing to advance blood safety products. Dr. Kenji, please.
Thank you so much, Brian, and thank you so much, Simon, for your great presentation. I just want to let you know that the town hall is that place where when you present, we have to be critical. You know, it's not a place where people sugarcoat things, right? So people will tell you what the thing is going to work. People will tell you what the thing may not work. And that's why I love the town hall, because it's not a place, for me to just come and I just say everything and it's like, hey, everything is okay. So I really appreciate all the comments that have come up, and I'm hoping that you can take these comments, and try to see how you can enhance the blood transfusion program there in Cameroon. I've had the opportunity to talk to Simon offline, and he has so much passion, and I really wish we have several Cameroonians with that much passion, to be able to drive things there on the ground. Even with the limited resources, I still think him struggling to see, what he can do to be able to improve, blood transfusion in Cameroon. My dad, before he died, had a lot of blood transfusion, right? So it is something that is really personal to me there. In terms of testing, most of what we do at Stanford, everything is molecular, right? Again, as Dr. Titanji said, even if you're using something like determine, right? Of course, you have somebody that already is carrying the virus, and it takes a very long time for that person to develop antibodies. So I think, Simon, my advice would really be that instead of the program trying to catch a big fish, we should really start from the basics, as Dr. Awasum said. Safety first. That is our hallmark at Stanford. Safety. We don't need to have 1 million pints of blood, right? And out of that 1 million, many of them are unsafe. It's better for you to have a little quantity of blood that is safe than having all these parts of blood that are unsafe. Now, there are two things that I wanted to just chime in here. And again, most of the things I wanted to say have already been covered. You have what is called a blood bank, and you have what is called a transfusion service. That's the way we structure it here at Stanford. So the blood bank is responsible for recruiting donors. So it's a bank. And it doesn't only service Stanford Hospital, it services almost the entire region here in Northern California. So what happens is that the Stanford Blood Bank goes out, they have a mobile truck, they recruit the donors, they manage all the donors, they manage the database. And what they do is once they recruit all those donors, they now do all the screening for the transmissible infections using all the algorithms that are in place. Then now Stanford Hospital is a client to the Stanford Blood Bank, same as you have other hospitals around. So they now go to the Stanford Blood Bank, then they now take blood from there. Once they take that blood, they are not screening for any transfusion transmittable infection again. They are now doing now the cross-matching and all those things. So those are two different things, right? The blood bank and the transfusion service. So you don't need to have 50 blood banks in the Northwest region. Because when you have 50 blood banks, you cannot control what protocol they are using to screen. Instead of spending a lot of resources trying to empower each blood bank, it may be as simple as, hey, you know what? I know one time they did this for medical schools in Cameroon. Everybody stop. Let's review. So it could be like, hey, let's put a pulse button here, then have a centralized blood bank. And in that centralized blood bank, you now implement all the protocols that you can implement. Then from there, hospitals can pick from. And you can have sub-centralized blood banks, right? So you have a national or a centralized system, just depending on the population, demographics, and all the like. Then from there, they can pick it up. Those are just some suggestions. Again, too, you are the one on the ground, and you can best see if it works in that kind of a setting. But I'm just sharing my own experience here, as to how we've done things and how I've seen things work. So I think ensuring the safety of the blood is very important. Then one thing, like each day we have a tier 3 report. We want to know a blood wastage because that is a big problem, right? It's not just going out and recruiting the blood donors, but if you are wasting blood, it becomes a big problem as well. Then how do you retain the current blood donors? That is something that you could also be focusing on because from your data, it shows that there are some people that do come back, right, in terms of retention. And something that I've seen work here is technology. So when you are a blood donor and you are keyed in the system, we know that after a certain number of days or a certain number of months, just depending on your criteria, you are due for the next donation. Then you just have an automated text message that goes to you saying that, hey, you are due for blood donation if you want to come for donation and all those things. So those are some strategies that I've seen work, in terms of donor retention. And again, too, I did talk about implementing component therapy. Yeah, but you can't really be implementing a lot of component therapy if the blood itself is not safe.
But I really want to say that implementing some of this component therapy is not rocket science. These are very, easy things to do in terms of platelet cells, fresh frozen plasma, and all the like. So I just wanted to, share some of those comments. But I just wanted to encourage you to, Mr. Simon, just keep doing the work that you're doing. Thank you.
Yeah, thanks a lot, Kenji. And Simon, I think Kenji also put some of those points in the chat as well. I think you can maybe have a chance to look at those. I think the key points he's made, he's sort of put them in bullet points in the chat, and I will encourage you to look at those as well. But we could save this as well and then maybe forward it to you later on. I think Dr. Kenji really highlighted some different ways in which this kind of surveillance mechanisms can be strengthened. He talked about molecular testing and really enhancing molecular diagnostics. He talked about retention of donors, reducing or minimizing blood wastage, and implementing component therapy in such ways. So really thanks a lot, Kenji, for those remarks. I do notice that Dr. Charles Awasum's hand is up. So I just want to give Dr. Awasum one maybe to make what comment he has before moving to you, Dr. Ta, and then Elvis. So please, Dr. Awasum.
Thank you. Before I really want to say, I really appreciate all the flowers that have been thrown at me, and I really like to smell them. Past 65, and I think I should really smell them really good. The just comment I want to make is actually that, Dr. Njoya actually is running a regional blood transfusion service, which is part of the National Transfusion Service. And why I said I feel sorry for him is because he's been given a white elephant. He's been given a title, he's been given a project that has no basis, it has no office. I don't know if he has an office, but I would suggest to him that he should start something little. Let him try to see how he can liaise and use the blood bank of the regional hospital as the regional blood transfusion service, so that there should actually be a refrigerator that belongs to the blood transfusion service of the regional hospital and a service that runs the regional blood transfusion service. I think that would be a way of starting rather than wait for when all the structures will be able to come in and all. That's the comment I just wanted to make, that there's actually a national blood transfusion service and every region is supposed to have a regional blood transfusion service that collects blood and services all the institutions. Why these other institutions are still running as independent components is because the regional blood transfusion service is not running. That was the comment I wanted to make. Thank you.
Yeah, thank you, Dr. Awasum. Please, Dr. Ta, please, over to you.
Thank you so much for giving me the opportunity. And thank Mr. Simon for the presentation. So I'm happy that he's there to listen to our cries. Okay, as Dr. Awasum said, that local problems require local solutions. I think I would like to suggest to Mr. Simon that the problem of storage of blood, I think it is feasible for us. Meanwhile, as well as the infectious, partial determination of the infectious, like making blood to be safe, with equally determining the immunological safety equally. Now, what I wanted to contribute was at a level of policy making, because as we all know, safety equally is associated with ODs with competence. Now, at the level of Cameroon, our policies are not well implemented. Like, for instance, integrated health centers in our nation do carry out blood transfusion, in which, according to the health system or algorithm, they are not supposed to do. And I think for Mr. Simon, he has the capability now, like, to implement that the competencies of the facility should be ensured before the facility carries out blood transfusion. Meanwhile, now, yeah, we equally thank the regional delegation for donating some blood banks and some fridges, but the fridges use electricity, in which is a very big problem here in Cameroon and in our facility. So we wish to plead that they should donate us solar fridges as they recently donated for the API project. That's the expanded program of immunization. They were solar fridges and they are very good and they functions very well. So I think if we can tackle or target storage, then ensure that infectious screening are done according to our level, then doing partial immunologic screening, I think we can pick up from here. Thank you so much.
Yeah, thanks a lot for that. Really great to hear that as well. Dr. Elvis, please.
Thank you, Brian. And once I join my voice with that of others to thank Dr. Awasum, I remember his days at the regional hospital. A lot of things happened, and we can only say thank you to some of the things you did there that we are reaping the fruits today. So many things in my mind, Brian. I'm going to do a lot of psychobabble here. Stop me if I get verbal diarrhea. But I just want to think about why was this called a bank in the first place? And I was doing a reflection. And a bank has to do with a bank as we take a financial banking situation. Now, when a bank has a crisis, and Dr. Awaso mentioned this, if you don't trust a bank, can you go there and put your money? Whenever there is just a rumor that Amity Bank or Bisek Bank is about to crumble, what happens? Not only do people run to take their money away, but nobody, the most important part is nobody goes to put his savings there. Based on what Bogoma said, if you can't trust the blood that is in the bank, it means that that bank has a credibility issue. Then what will happen? Let's equate savings to storage. Yes, you're talking about putting blood in the bank, that's saving money in your account. But what happened to the deposit account? Once there is credibility issue, there'll be issues of deposits. Nobody will come to deposit his money. So then there'll be less blood donation because there is credibility issue. So anything that has to do with credibility of the quality of blood in that bank affects indirectly those who come to donate blood to be saved in that bank. I've used a lot of thinking about the hypothesis of how a bank operates to think about blood transfusion bank or blood banking with a financial banking institution. You just mentioned about the refrigeration, Dr. Ta. A blood bank, like a bank, is not just a safe. A bank is not just a safe, the vault where they keep the money. It's an infrastructure, which means it has a building, which means it has workers. Then the safe is just one component. So that refrigerator is just one component. So each time we are advocating for a blood bank, we keep on advocating for the safe, the vault where the money will be kept, forgetting that a bank is the infrastructure, the building, the access, the workers. Then the safe, which is the refrigerator, just become one component, just one single component. Then that brings us to the point where there should be a big building in each region of Cameroon, all the 10 regions. If you call it a national blood bank, we need to see a big building. If the government can spend 1 billion to build Hotel de Ville for regional councillors, which is going on in the upstation in Yaoundé, 1 billion francs to build Hotel de Ville for all regional councils. That's where each time they come to Bamenda for their meeting, they should go and lodge. If that same 1 billion can be used to build an infrastructure where you call the blood bank, and then that's the bank. Before you even start thinking about the refrigerator to put in the bank, which is just a safe aspect when you go into a financial bank. So use this anecdote of a bank and how a bank functions. And whenever there is a crisis in a banking institution, what happened to its clients? Let's go back to the aspect of clients. You have deposits as mentioned as donation. Deposit in your savings account or checking account, that's blood donation you are putting in the bank. But then let's go to withdrawal. What happened when you put money in your deposit account or even your checking account, as they call it here, and you go to withdraw now to use withdrawal? That's you're going to withdraw. That's transfusion. Withdrawal is that level of transfusion. Now you need to pay money. It doesn't work in a banking transaction. That I keep my money, then I go to get it back, maybe then I pay more money than the one that I kept inside to get my money back. Logic. It doesn't work. So government has to put in a lot of money in commodities, subsidize the commodities for screening that blood. Because what increases the blood cost when you go to withdrawal or transfusion in banking and blood transfusion, as Dr. Awasum said, is the cost of making that blood safe. The cost of testing for HIV, testing for syphilis, testing for hepatitis, and testing for all those infectious disease raises the cost of the blood, of withdrawal. Now, in banking, there is what we call now interest on your savings. So if that blood had been saved there for over a time, those who donated it, what is their incentive? And that's why Dr. Awasum talked about what sandwiches. That was just a basic interest that those guys got prepaid for saving that blood in the bank. So minimal. You don't even have the sandwiches. Thank God he had it. You don't even have sandwiches from what you said, Simon. Such a pitiful situation. But I think that if you do the anecdote between financial institutions and blood transfusion, if you want to call it a bank, then you will realize where we are on this journey. But what are some of the opportunities? The minister last week painted a situation of a policy they have taken for 3-test algorithm for HIV in Cameroon as one of the ways to eliminate HIV. They have gone into the 3-test algorithm for testing for HIV. They are about starting this piloting of the implementation of the 3-test algorithm, which the blood transfusion program should take advantage of this and make sure they follow that algorithm. But in that algorithm, there is also the testing for pregnant women, the dual testing for HIV and syphilis, which is not a dual test, which means on a single test, you can test for HIV and syphilis on a single test strip. It's available in the country, and they are doing that for all pregnant women during their antenatal clinic, as WHO requires they should test 3 times during their gestational period. So the blood bank should take advantage of this new algorithm of the National HIV Testing Program, which includes the dual test for HIV and syphilis, to make sure that syphilis, as Dr. Awasum raised, Dr. Buguma raised, is a very important infection that should be screened during blood transfusion. So you can just do that by using the dual testing for HIV and syphilis. So I just wanted to share this reflection because as you were speaking, I kept my mind into the bank, and I was using all these anecdotes to try to just imagine and to share with you that a bank is not just a safe. It's an infrastructure, it's a process, and it has its own real management system, which we should use that same anecdote to look at blood bank through that lens. Thank you.
Yeah, thanks, Elvis. I really love that anecdote or that parallel you drew with the financial, really equating the blood transfusion system to a financial banking system and how important it is to build credibility and trust. So thanks a lot. So I think we're nearing towards the end. We typically try to end by at this hour. It's about 1 p.m. I think, 2 p.m. In Central Time, I believe 3 p.m. in Eastern Time. So I just wanted to maybe give an opportunity to our chair to maybe give some remarks. Then I will maybe we start with Simon. I probably maybe give some of your closing remarks, and you've heard all the comments that was made. I'm sure you've taken the points that Dr. Awasum made. I think he really made a great point that you should consider making a liaison with the Bamenda Regional Hospital's blood bank and probably using that as a foundation for the regional blood transfusion service rather than waiting for the national policy or the national program to be to really be established. And I think that might be a great place to start as well. And I think that many of the comments that whether Dr. Bogoma made or Dr. Kenji or some of the points that I think Dr. Elvis has made as well are really valuable. So just wanted to hear your closing thoughts and your closing remarks. Simon, over to you.
I would start with Dr. Awasum and what he proposed. We are already working with the regional hospital as a referral bank for all the various district health services as well as integrated health centers. So they
I have a very close collaborator, Mr. Agofi Davis, that supervised the bank, and we work in collaboration to make sure that this is the referral bank in the region. So his advice was already taken into consideration. When it came to integrated health centers that transfuse that are involved in transfusion, we are trying as much as possible to limit the expansion of transfusion activities to integrate to the creation of more transfusion centers. And we are trying to bring to centralized at the level of the regional hospital. Like, you know, in the Northwest, the highest ranking hospital we have is the regional hospital. So we are trying to centralize these services to the regional hospital. And when it comes to basic regulations that have to do with transfusion, there are articles that we are working right now at the level of the National Blood Transfusion Service in order to be able to make sure that we can regulate activities in terms of safety, in terms of screening, and in terms of collaboration with the already existing blood banks. And then when it comes to the dual testing, this is a novel. This is actually a good information for us to exploit. Like Dr. Dasi said, we were involved in the HIV triple testing method that was initiated. We were associated to the meeting, but I got new information about the dual testing today that I wasn't aware of, and I will try to relay it to my authorities, because that is an opportunity that we can take hold of, and we can even have reserve testing kits, as I mentioned, as part of the plights to the presentation I made. But as my concluding statement, we are taking baby steps, and we are focusing on the immediate things that we can change and the little things that we can change, because it is good to dream, but sometimes your dreams are limited by the finance that you have. And we can do all of these things without necessarily waiting for someone if we pull ourselves together, and if we can support initiatives, grassroots initiatives that will lead this. This is not rocket science. This is something that needs a lot of collaboration, needs a lot of, I don't think providing a sandwich to somebody needs us to study cookery to do it. But if we pull ourselves together, pull our resources together, pull our intellects together, then we can treat the region and consequently the country and set the pace that we desire so much to see. Because one thing that is clear is we can't keep waiting for time, which will never be on our side. We can't keep waiting for time. We can start somewhere. My plea here was just that we begin from somewhere. We can choose the basics and begin with, like, trying to raise the donor database, trying to unify the testing methods for safety, trying to build confidence and demystify what donation is all about. That was actually one of the basic things that I wanted to pass in, and get to know and get to meet and get the suggestions that all of you, my elders, have given me today. I've just washed my hands to sit at the table. I don't think I've started eating yet. So I am still open for you to see and check the hands if they're clean. And if you wish, then I can share in the meal and provide the solutions that we need on the ground. That was my aim for attending this meeting. Thank you so much. Those are my closing remarks.
Yeah, thanks a lot, Simon. That was very deep. I think I'll take a final round before we hear from the chair of the Cameroon Town Hall to close the session for today. Just want to give my co-moderator, Dr. Elvis, to give some of his closing remarks as well. Elvis, please.
No, I wanted to say that through the lens of the town hall, we look at the hands and they were very clean. It was just waiting for Mono to serve the food and we start eating at the level of the town hall. And one of the good food that Mono, our chair, has served is that we had a consultation at the background and the town hall has decided that he asked me to say this, that because we look at the hands and they are clean and we've decided to eat with you, the town hall is going to do a donation of 1,000 duo tests to the regional hospital. And you're going to manage that. You're going to have 1,000 HIV syphilis combo tests to use for your blood transfusion program. That will help you to screen people for HIV and syphilis. And if that can help 1,000 blood screens, then that's the fruit of the town hall to show that the hands are clean. Thank you, Brian.
Yeah, thank you. That's very helpful. Thanks. I just want to transition to Dr. Foma.
Thank you. Thank you so much.
Brian, I will tell you one thing is that after talking to Simon, I realized one thing. He's one of those things Cameroon needs, a person who is full of passion, who is full of innovation, and he's data-driven. Because there are a lot of things in Cameroon that we don't have data about. He's data-focused, data-driven, and really wants to make a change. So as part of the town hall, we're going to assist in our own little way, as Elvis said, in order to drive this ambition forward. And I think you do have a lot of people here in the town hall you can work with. Some of them asked you pertinent questions like Kenji, like Professor Boguma. She's at Emory and she has a lot of experience you cannot imagine in Cameroon and out of Cameroon and infectious disease. So there are a lot of people you can really collaborate with. And in order to gather data, in order for us to even know the situational analysis and actually move things forward. And we are happy to really have you at the town hall today. Looking at blood bank medicine, I deal a little bit with blood bank, with the hematology part of it, the supply chain, we prescribe it, but there's blood services, which is different from a blood bank. So I think going through this, I know you do have issues with donor recruitment and retention back home, and that becomes a big issue. You do have issues with safety, short half-life for these cells that have to be kept, especially when you're keeping them as whole blood, their half-life is pretty short, and the preservation becomes an issue. There is an issue with infection and infectious diseases, different types of them that need to be localized. We need local solutions and be able to test them and give adequate, what do I call, guarantee to the population that is coming to receive blood. So they should actually know that what they're getting is safe. And I would tell you too, I know someone who donated blood months ago in Cameroon, and later on, a few months later, was found to be hepatitis B and has been a constant donor. So it strikes my mind that these people truly have a reason to be scared. Now there is issues of shortage and handling of that blood. There are issues of legislation and regulations around blood transfusion. There is issue of cost. Those things have to be managed at the central level, where we should be able to have real operations and get to the point where ethically we can provide blood safely. We can get people donate blood, and this blood can be given to those who are in need without them paying any extra money for this blood. So I just want to thank you for having accepted our invitation in a short notice. And we had the opportunity in the town hall. We've been existing for 3 and something years, but this is the first time we've really talked about blood bank medicine and blood transfusion. And I hope you would be a constant participant in our town hall, and also you may find people here that you will collaborate with. And the town hall would start by trying to help you with the testing and also provide a level of confidence that the people will get by really trusting your services. So Brian, thank you. And Elvis, thank you for the moderation. And I also want to thank all those who are here, especially I'm happy that Professor Boguma Titanji made it. and also Professor Kenji. So you guys have a wonderful day, and thank you, Dr. Awasum, for everything. You know that. So, and for being a father and being also a mentor to all of us here. It was a pleasure having you in the town hall. And we look forward to also inviting you so to come in. The town hall is open for anyone who thinks they have a bright idea to change Cameroon or to talk about a particular problem. You had a lot of experience in Cameroon working as a surgeon and working also as a director for multiple years. So if there are things that we can do to move the country forward, we are willing to have you here at the town hall and listen to your advice and your guidance.